So let's get started with today's guest speaker. And I got to tell you, so we do all these courses here at Glidewell on dental sleep medicine. And then what we found is that most of the doctors that take these courses do not go on to develop large sleep practices. And the biggest hindrance is figuring out how to get paid. And that's where today's speaker comes in. Randy Curran is the founder and CEO of a company called Pristine Medical Billing. He's worked with over 1,000 dental practices. He's helped obtain medical insurance coverage for thousands and thousands of patients. And we had him at our dental sleep medicine symposium, and he was one of the most popular speakers there because he's got really three tracks that you can follow to as logical ways to get paid. That some you can choose one or more than one, but it's a way that will work for you and help you make this move into what we see as a potentially very productive area of dental sleep medicine. So I'm going to turn this over to Randy Curran. I'm delighted that he's joined us today, and he's going to talk about dental sleep medicine pathways for financial success. Take it away, Randy.
Thank you very much, Dr. Park, and thank you for having me on. It's an honor to be here today. So just going to confirm real quick that you can see my screen.
Yes, it looks great.
We're good to go. Okay.
Thank you.
So good morning, good afternoon, everybody. Thank you for joining. Again, thank you, Glidewell, for having me on to share this information. And as you mentioned, Dr. Park, it is very difficult to navigate the financial side of dental sleep medicine. Doctors, I've worked in this industry for about 15 years now, or in sleep medicine for about 15 years, the last 11, going on 12 now, just helping dental practices help their patients obtain pre-authorizations for treatment to use their medical insurance to get coverage. It is very challenging to understand and navigate your way through the financial side of dental sleep medicine. So what I want to do is just kind of talk about those three ways. Then when you're using medical insurance, obviously you can be a cash pay practice and not use medical insurance at all. But a lot of patients, once they understand this is a medical condition and they have medical insurance, they are going to want to utilize their medical insurance one way or another. So what I want to do is just kind of walk the audience through the three different ways that we've seen, the different models, and talk about the pros and cons of those models so that you can determine in your practice what would be best fit for you moving forward with dental sleep medicine. So let me get this going here. So like we talked about, there's three different ways. And the first one is a fee-for-service model. So this would be a model where I'm sure a lot of you are familiar with, and there's a lot of what we hear boutique practices out there that they're a cash-based model, whether it's for dental sleep medicine or for just dentistry in general, or a fee-for-service model. And this is going to be a model when it comes to medical insurance that you're going to collect the fees up front from the patient. But you're still going to have the patient use their medical insurance the best they can. So you're going to collect the fees up front from the patient. You're going to pre-authorize the treatment through the insurance because the patient will need that a lot of the time. Because of the dollar amount being charged to the insurance for oral appliance therapy and the criteria required to meet medical necessity for oral appliance therapy, most insurances do require pre-authorization for this treatment. I would assume if I was in a practice that every insurance requires pre-authorization. If they don't require pre-authorization, maybe it's an Aetna plan. A lot of times they'll offer a predetermination. So you do want to always have that done. So even if you're in a fee-for-service model, you want to take the time and help the patient get the pre-authorization or do a predetermination for the patient. So it's much easier for them to get that coverage and get payment back from the insurance. I mean, this model is going to be, whatever the fee is going to be. Typically what we see as a fee, depending on the demographics of the practice, is going to be anywhere from $2,000 to $3,500. So obviously, if you're in Manhattan, Beverly Hills, Los Angeles area, it's going to be, or Bay Area in California, it's going to be on the higher end of that versus if you're in Alabama or Arkansas, where you're going to be a little bit lower just based on the economy of the area. So what are the benefits to this model? So Obviously, it's going to be consistent upfront revenue. When you talk about using medical insurance, there is a time period that you have to wait for payments. That time period could vary depending if you're in network or out of network. And it can vary from 3 weeks to 12 weeks to get that payment from the medical insurance. But with this model, you're going to be collecting everything up front from the patient, or the patient's probably or may go on a payment plan or use care credit or whatever that may be. But it's going to be consistent upfront revenue. So I know that's attractive. Nobody wants to wait for money, or nobody wants to chase money. So that's going to be one of the big benefits of that, is it's always consistent revenue coming to the practice, right away. You also have the freedom to set your own fees. You can do this in an out-of-network model as well, but whatever fee you determine for your area is a fair, reasonable fee for your patients. You have that freedom. You're not bound by any contractual obligations to the insurance company on what fees they may be. So you can always set your own fees for that treatment. And then when you're using this versus a cash pay model, it's very similar to a cash pay model, but you're giving the patient the opportunity to work directly with their insurance. So we see this a lot with TMD. So we have a lot of practices that are doing dental sleep medicine and doing TMD treatments as well. And TMD is very challenging to get medical insurance to cover it. And what part of TMD do they cover and what part don't they? And what insurance covers what? So it's very challenging as far as that goes. So you'll see a lot of these practices that they want to, help the patients use their medical insurance, especially with TMD and sleep together. But they also want that collection model where they're collecting up front and they're not relying on the insurance to make this profitable for them or waiting for those payments. So we'll see that a lot with TMD practices, sleep and TMD practices, where they're doing the fee-for-service model and they're giving their patients a pathway to the reimbursement directly from the insurance. And the benefit to that is the practice themselves, they may get the pre-authorization. Sometimes they may get the gap approval, which I'll talk about here in a little bit. But for the most part, they're not fighting with the insurance on the claim side on the back end. They're letting the patient work directly with their insurance. And obviously, that's going to save them a lot of time and labor so that they can focus on treatments and business growth instead of dealing with medical insurance on the back end for payments, especially if they're out of network in this model. So that's going to be a big benefit. And just letting the patient work directly with their insurance is going to help quite a bit for the dental practice. Just save them the headache of that. So what are some of the challenges for this model? What you'll see is the patients like to use their insurance in a traditional way. So that's going to be a challenge. If a patient comes in and they were referred from a sleep physician, or they were coming off of CPAP or BiPAP treatment, any kind of PAP treatment, and they want to move into oral appliance treatment, a little bit less invasive, maybe easier to use for the patient. They know it's medical, and especially if they just use their medical insurance to help cover their PAP treatment. And this will be a challenge because the patients are going to just want to use their medical insurance the way they would use their medical insurance, seeing a DME provider for PAP therapy, seeing their local physician for a visit. They just want to pay their copay or their responsibility and not have to pay the entire amount upfront and wait for reimbursement from their insurance carrier. So obviously that's going to be a challenge to your patients to close those cases. The other challenge is going to be, it's going to be difficult marketing yourself for physician referrals. So physicians, if you're working with a cardiologist, a pulmonologist, ENT group, whatever it is, or even local PCPs, if you're working with the medical community, they're going to want to see that their patients can, receive that treatment and be able to afford that treatment. What they don't want is them to refer a patient to you to treat that patient with dental sleep medicine, and that patient come back to them telling them, no, I couldn't afford it. They wanted $2,500 up front, and then they wanted me to work directly with my insurance carrier. So that's going to be a big challenge if you're trying to branch out, you're trying to grow the dental sleep medicine side of your practice, and you're trying to work with the medical community, because the medical community is used to referring to other providers that are going to use their insurance and the patient's medical insurance in a traditional way. So this will be a challenge for you as well in that fee-for-service model. All righty. And then another thing is the insurance carriers, they like to control where their patients go. They want to choose the path of the patient's treatment as much as possible. And obviously medical insurance carriers, they want to control cost. So when you go to do a pre-authorization or a pre-D or a gap approval with the insurance to help get this treatment covered, and sometimes you have to do this, it's not an option. If this treatment and these codes do require a pre-authorization, there's no way around it. So when you're in this model and you're collecting upfront and helping your patient get that reimbursement directly back from their insurance carrier, when you go through the pre-authorization process, the insurance may direct that patient, and we often see them do this. They'll send a letter to that patient and advise that patient that there is an in-network provider close by. So if you are practicing near an area that's a larger metropolitan area, you will be faced with that challenge where there's going to be in-network providers around you, and you are going to lose some patients to those in-network providers because the insurance carrier decided to direct that patient in that way to an in-network carrier where they can control the cost on that. So that is something else you got to watch for. It's a challenge if you're in an area that doesn't have any in-network providers. And a lot of times with TMD practices, like we talked about, they don't face that challenge very often because there's not a lot of in-network TMD providers. So this is a little bit easier model for them because the insurance isn't going to be able to move their patient to an in-network provider. But if you're treating dental sleep medicine and you're using this model, and there is somebody in your area within typically 30 miles of you or 50 miles of you that's an in-network provider for the insurance carrier, that insurance carrier may send that patient and try to move that patient into to a different provider. So that's always going to be a challenge as well. All right, so who's good for this model? From what we've seen, it's going to be a practice that, like I mentioned, kind of more that boutique practice, or that practice that probably doesn't take dental insurance either. They're very good at selling cases. They already use this model in dentistry. So they're already using a fee-for-service model in dentistry. And they're already treating patients for TMD. So this is one, like I mentioned, if you're good at selling and you already use a fee-for-service model and everything else you do, and you want to implement dental sleep medicine into your practice, then yeah, this may be a good model for you. And especially if you're doing TMD treatments as well, because that's the easiest path to work with medical insurance for TMD. All right. So we're going to move on to the next model here. And if you have questions, I'm sure every time I speak, I get a ton of questions. So I'll look forward to answering all those questions towards the end of this. Yeah, please put some questions in there. I guarantee you we're going to have a lot of interactive, communication at the very end of this. So out-of-network model using a gap approval. So this is a second pathway that we're going to talk about. It's going to be out of network. Most dentists that we work with, I would say still, even with the move of a lot of these dentists moving towards an in-network model, I would still say 65% of the dentists that we work with are out of network. So they may be in network with some of their dental insurances, but with dental sleep medicine, they're using an out-of-network model. This is a model that was extremely popular when I got into this, because there wasn't a lot of in-network dentists. The medical insurance carriers weren't offering medical contracts for dental sleep medicine to dentists. So it's really the only way to move forward and still kind of use the patient's insurance in a traditional way, where the patient's only paying their portion up front. So the out-of-network model using gap approvals. What is a gap approval? A gap approval is when there is not an in-network model or an in-network provider within 30 to 50 miles. So each insurance has different criteria. Some use a 30-mile radius from the patient's residence. It's not from the practice, but it's from the patient's residence. If there's not anybody in network for 30 miles, or if there's not anybody in network for 50 miles, then they have there's a gap in coverage there. There's a gap in coverage of providers who can provide this treatment that are in network. And you'll see this a lot in rural areas, but in some of the bigger cities now, a lot of the dentists are moving to the in-network model. But this is good in a sense where you can still have the freedom to set your own fees. You're going to stay out of network and just depend on the insurance to supplement that. That gap approval is when there isn't that provider that's nearby for the patient. An out-of-network provider can use the patient's in-network benefits helping that patient with a lower deductible, lower cost share, like a co-insurance, and still be able to set their own fees. So who benefits from this model? This would be somebody that's in a rural area. So, and again, everybody would know their area. Major cities like, out here in San Diego, it doesn't work well, within 30, 40 miles of San Diego. Maybe where I'm at, I'm about an hour northeast of San Diego in Temecula. Yeah, it could still work in this area, but if you start heading towards Orange County or start heading towards Los Angeles, it's not going to work. I know Chicago has a lot of in-network providers. Seattle has a lot of in-network providers. Most of the major cities now have in-network providers, but this will work well if, say, you're 40 miles, 50 miles outside of a major city and you don't have an in-network provider. This is where you can still get those gap approvals and you can still stay out of network. You don't have to contract with the medical insurance and get the gap approvals to still help the patient use their in-network benefits. So with this one too, you have the freedom to set your own fees, just like that fee-for-service model. You're not bound by a contract. You can set your fee at whatever you think the market rate is in your area. So you have the freedom to do that as well. And then this is that gap approval. So this is what I'm going to go into those gaps approval a little bit more and show you what that looks like for those patients. But this is when those patients can see you as an out-of-network provider, but use their better in-network benefits. So this would be a typical patient's in-network benefits. You can see here, in-network, the deductible has been met, or not been met, but close to being met. It's much lower than their out-of-network deductible. What we call cost share, co-insurance, patients co-insurance, we call it cost share. Their cost share is different. It's 20% different being in network versus out of network. And then you have maximum out of pockets. And this is something I'll bring up to you guys real quick too, because we're coming to the end of the year. And at the end of the year, a lot of patients who may not have been able to afford the treatment early in the year may be able to afford the treatment now. So not only, like, if you were doing case presentations to some patients in, say, March, February, April, even up to May and June, and that patient couldn't afford it, they still had all of their deductible or a lot of their deductible remaining, it was going to be more out of pocket to the patient. We always advise our practices to circle back to those patients. Take a look at all those patients. You could have 10, 15 patients, 20, 30 patients at the beginning of the year that you did a case presentation. And the only reason they didn't move forward with treatment is not because they didn't want the treatment, not because they want to live a better life and be in bed with their partner again, and not being kicked out for whatever reason. So this would help that patient, because now you can come back, look at that patient's insurance and determine, okay, yeah, now this patient may have met their deductible. And even better, maybe that patient has met their maximum out of pocket. So with dental insurance, they have a maximum out of pocket that the insurance is going to pay for the year. So it's not really a max out of pocket, it's more of a max payment from the dental insurance, where medical insurance has a maximum that the patient will pay out of pocket for the year. So right now, we do about 2,000 benefit checks a month. And right now is when we start seeing a lot of the max out of pockets starting to be met. So in September, in October is a great time. You can go into November. You don't want to wait till the end of the year, because then it's going to be very difficult to get that delivered in time, because the insurance gets backed up on pre-authorizations. But right now in September and October is a great time to look at all of those patients who couldn't afford to move forward with their treatment and check their benefits again. You may find 5, 10, 15 patients who have met their deductible, and maybe even find some that have met their maximum out of pocket, and the insurance is going to cover a very large amount of the treatment now. So that's just a little side note there for those that are doing this and maybe couldn't, convert some patients early in the year, and maybe those patients really wanted the treatment, they just couldn't afford it. But this is, you could see, going back to the gap approvals, this is a big difference here on using the patient's in-network benefits versus using their out-of-network benefits. So some of our competitors in the industry, they've actually stopped doing gap approvals because it is a little bit of extra work. But you're doing it for the sake of the patient. You're doing it for the sake of the patient being able to afford the treatment. So yeah, is it going to be an extra step? Yeah. Sometimes do you have to get that patient on the phone with the insurance company? Yes, because some insurance policies will require, they do approve a gap, they do offer a gap, but they require a patient to initiate it. So, and there's different terminology for this. The most common is gap, but they also call it a network deficiency coverage. They also call it a in-network exception. So there's a couple different ways the insurance will use the term, but it all means the same way: gap, network deficiency, in-network exception. It all means the same, where the patient can use their better in-network benefits because they don't have an option to see an in-network provider nearby. And it is a little bit of extra work. And sometimes the patient will have to get on the phone with the insurance carrier, but it's worth it. We do three-way calls with our patients all the time because the patient doesn't know what to say, what to ask the insurance carrier. So what we do is we schedule those calls. We walk the patient through those calls with the insurance carrier to ensure that they can maximize their insurance benefits. And again, this will still work for practices that are outside of an area that have contracted providers. And you can see if we're using an allowable, like just a typical insurance allowable of $2,200, if you're using that allowable, what the insurance is going to allow for the treatment, and you get the gap versus not getting a gap, it's a huge difference. You're over $1,000 payment. So if you're trying to collect $2,200 from the patient, or 25, getting that gap approval is going to make a difference. It's $1,580 versus $420 without the gap approval. So it's over $1,000 you're going to help save the patient. And that could make the difference of moving that patient into treatment or not. So again, this will work well. It does take a little bit extra work to do it, but it's well worth it if it's available in your area. And these are the payment trends, just to kind of give you an idea with the gap. These are Aetna is anywhere from $2,200 to $2,800. Blues vary quite drastically because each blue is state driven and not nationally driven. So if you look at California, we have three different blues. We have Blue Shield, we have Blue Cross, and we have Anthem. They all work independently. They all have their own policies. They all set their own fees. Out in Washington State, you have Regents, you have Premera. Maryland, we have Care First. So there's a lot of different names of the Blue Cross and Blue Shields across the country, because even though the parent company is Anthem and traded on Wall Street as Anthem, they're all separate entities within the state, and even multiple entities within the state. And that's why you see such a big difference in pricing, because they set their own fees depending on the states that they're in. You also see a big difference in pricing based when you're out of network using this type of model. You don't have a contracted rate. So you may have Aetna or Cigna or United or Blues pay you $3,000 for one patient, but pay you $1,200 for the next patient. And those patients could have had the same deductible, same cost share, same everything. It didn't matter. What mattered was how the plan was funded. What type of plan was it? And if it's a well-funded plan, it's going to pay better versus maybe a less funded plan. And you don't know that being an out-of-network provider because you don't have a contracted rate. And that is a big challenge when you're doing this out of network. But that is why that's why if you're a provider and you've seen Blue or a Cigna pay you, $1,200 on one patient and $2,500 on another patient, it doesn't always matter just because of deductible and coinsurance. It's just how the plan is funded versus, and you're an out of network. So there's no set price for you. All right, so Cigna is $1,500 to $2,400, TRICARE $2,200 to $3,200. The good news about TRICARE is even if you can't get a gap approval, they have great out-of-network benefits. Their deductibles are typically only $300, both in and out, and the difference coverage is typically 100% in, 75% out. So TRICARE, if you're struggling with gap with TRICARE, that's not a big deal. You can use their out-of-network benefits and still generate a good payment from the insurance. United Healthcare is probably the toughest. They're the bad guys in the entire medical industry, billing industry right now. And their allowables are only like $1,100 to $1,500. And they used to actually be one of the best a few years ago. So these are your payment trends with gap. This is what we're seeing across the nation when we get the gap approvals. All right. So what are the challenges to this model? The first challenge is just going to be a slower process. So you're going to have slower pre-authorizations. Like I mentioned, you're going to have the patients have to get involved sometimes during the pre-authorization process, because now you're not just getting a pre-authorization, you're also getting the gap approval, the in-network exception, the network deficiency, whatever the insurance is calling it. You're also going through that process as well. which would take maybe normally 2 weeks for a pre-authorization, may take 3 or 4 weeks, because not only are they pre-authorizing, but they're going through the steps to ensure that they can also get the gap approval for the patient as well. The other challenge to this model is payments. Payments can be slower out of network. They're always going to be slower out of network. And then they're even a little bit more slow with a gap approval. And many times they'll process it incorrectly, because the insurance, I would say 98% of all the claims that go to the insurance company are in-network straightforward claims. Using out-of-network services with a gap approval isn't something that the insurance does very often. We're kind of a niche business on that side of it. In the insurance eyes, we're not a frequent flyer per se. So they do make mistakes. They will process claims. They'll process the claim as out of network, and they'll forget to use the patient's in-network benefits. And you got to send the claim back to get reprocessed. So it is going to be a little bit longer to get correct claims paid. The whole process with gap approval is a little bit longer, but yes, it does work. It does give you the freedom. You just have to be patient with the pre-authorization process, and you have to be patient with the claim payment process. And you have to understand they will probably pay your claims incorrectly, probably 30% of the time, and you'll have to send those back for reprocessing and adjustments. So that is one of the negative parts of the gap approval process, or the gap system there. Like I mentioned, it doesn't work well in larger cities. You're going to be faced with a lot of in-network providers in those cities, and they're going to deny your gap approval. And not only deny your gap approval, but again, try to send that patient to an in-network provider during the pre-authorization process. Okay, so that was it on the staying out of network and using gap approvals or in-network exceptions to help your patients move forward with the treatment. Again, could work pretty good in a rural area if you're patient with it, but it's not going to work good if you're in any kind of area that has in-network providers for dental sleep medicine. So the third option here would be to go in network with medical insurance. That's probably the fastest trend in our industry right now. Is a lot of dentists are moving to the in-network model, especially those dentists that want to create some volume and have been frustrated. Maybe somebody down the street got in network and they can't get gap approvals anymore, so they're trying to get in network before the networks close. And that's what we're seeing quite often now. The insurance carriers, like I mentioned before, it was challenging to get contracts for dentists, get a medical contract for a dentist treating dental sleep medicine. That changed about 4 years ago with Cigna. They really started opening up their arms to dentists treating dental sleep medicine. They actually carve out a separate contract where it's an all-inclusive contract. And that contracted rate, I'll show you the rates here in a minute, but that for Cigna is anywhere from like $1,900 to $2,500. And that will include the doctor's time during the consultation. It'll include the doctor's time during delivery, the appliance, and any imaging. But Cigna was the first one to come to the table and recognize the need to start creating a dental sleep medicine network so they can start controlling the cost, controlling where their patients, where their members, what providers their members see. And after that, United Healthcare got on board, the Blues got on board, and Aetna's finally, this last year, Aetna's finally opening up their arms to dentists that want to become in-network as well. Right now, United Healthcare has actually closed their network with this because they feel they have enough right now in most of their areas. They'll probably reopen that in 2024. But at this point, United Healthcare has been closed. All right. So these are the contracted rates. This is what we see. The first question I get from dentists when we talk about going in network are obviously going to be, what are the rates? Is it going to be profitable? Is it worth our time to go in network? And I always hear that, they don't want to be contracted. They're not contracted with any dental insurance. And it's a lot different. Medical insurance versus dental insurance is night and day. I know a lot of dentists, it's stigma out there. You don't want to be in network with any insurance carriers, but with dental sleep medicine, that's changing. And it's not the same as being in network with dental insurance. So these are the contracted rates. $2,000 to $2,400. Aetna offers what's called a professional services contract. They're going to offer you a contract where the appliance is probably $1,600, $1,700, and then the other services you provide for that patient will be paid as well. So unlike Cigna has exclusive dental sleep medicine contract carved out, Aetna uses their professional services contract the same way they would, offer that contract to a physician. So the doctor would be able to get obviously the appliance, a couple office visits, and any kind of imaging that's being done in that practice. So when it's all said and done, the Aetna rate is between $2,000 to $2,400. Blue Cross Blue Shield, again, that's going to vary based on state. I think Wyoming's the lowest, around $500 to $600 there. So I don't have anybody going in network in Wyoming, obviously. 926, 979, we'll see that like in Texas or Alabama. Some of the Southeast states will be on the lower end of that. And then some of the better states for the Blues across the nation, you have Illinois is at 2,080, Michigan's 2,456. South Carolina is pretty good. They're at 2,200 versus an out of network rate at only 1,100. Maryland's 2,000. Regents up in out here in the Northwest, they started offering contracts. They're really building their network out right now, and they're 2,500. So it's going to vary, obviously, on the state that you're practicing in for the Blues. Cigna, they're 18 to 2,400. Again, I mentioned they have an exclusive contract there. And then TRICARE, 2,600 to 3,400. And United Healthcare, 1,500 to 1,800. And like I mentioned, United Healthcare is currently closed. All righty. So those are the contracted rates. Making it work in network, you can kind of see here, because that's the biggest question we get is, if it's only 2,000 or 1,600 or 1,800, how do we make that work? Obviously, you got to watch your costs. Like with anything else, you're going to have to watch your cost. If maybe you're used to making 2,800 or 2,600, and now you're going to go down to like 2,300, well, where do you save those costs? The first thing I'd say is appliance. There's a lot of appliances out there that are very expensive, $700 plus. 7 to 8. I don't know if it quite gets to 800, but I know there's a lot that are 6 and 7s out there. That's going to be it's going to be a challenge if you're in network. So you got to really watch your appliance cost on that. Try to get your appliance around $300. 175 is going to be if you're using a third party billing service. Typically for that, it's going to be around 175, $200 for your billing and the pre-authorization and the patient quotes. And then $400 typically is going to be about an hour of dentist time, especially if you get good at this. The dentists that we work with that are doing like 30 plus per month. I've worked with a lot of clients for probably 10 years now that are doing volume, and they don't have to do a lot of the work. Their staff does most of the work. The dentist's going to come in for, obviously 10 minutes, 15 minutes here and there, talk to the patient, but their staff is doing it. But to say, for example, you're as a dentist, you're going to spend 1 hour of time, staff spends a couple hours of time, and maybe this is a rate, with benefits and things like that. Your margin is going to typically be about $925 there. So about $1,000 per patient. And what we notice with our practices going in network is their volume dramatically increases. So our practices that are typically treating 2 or 3 patients per month, once they go in network, they're going to get those patients up to about 10 to 20 per month. So pretty easily, you'll be able to add another $10,000, possibly up to $20,000. And, you think, okay, I'm in network, I'm not getting as good as rate. I'm getting $300 or $400 more per patient out of network. But you're going to triple, quadruple, or even more than that with your patient volume coming in. And you also won't waste as much time on case presentations that don't move forward. Most of your patients, when you're in network, are going to say yes to treatment. All right. So what are the benefits of going in network? So let's go through the benefits, the pros and cons of going in network. The first thing you're going to do is you're going to be able to close a lot more cases. Like I mentioned, one thing that I know is very frustrating for dental practices getting into dental sleep medicine is they spend a lot of time, working with these patients, doing the workup, getting the patient tested, sending it out for testing, getting the sleep physicians involved. And then when they go to present the case and they're out of network, maybe they're using that fee for service model, maybe they're using the gap model, but they don't know for sure if they're going to get the gap and it's kind of questionable. they typically only close about 30% of their cases. So the out-of-network dentist, whichever model that they're using, they're probably only, based on our data, they're converting about 30 to 35% of their cases. And that's challenging. So that means 7 out of 10 people that you're presenting to, or 6 out of 10 people that you're presenting to, they're walking away, and your staff wasted their time. I would say wasted their time because they at least brought awareness to the patient. But it's frustrating for the staff because they're not closing these cases, and they're not closing it because of the financials, right? So when you get in network, we see that typically that goes up to about an 80% capture rate. When we see our practices, everything comes over to us. We do the pre-auth, we do this, and then whether it converts to a claim or not, we track that data. We have about 700 practices that we bill for, so we have a pretty good size pool of data, and we can understand where that's going to make a big difference on those practices that are going in network. So they're closing about 8 out of 10 of their cases in network, and their team is feeling victories all day long because they're helping these patients. They're getting these patients into treatment. So that's a big bonus. And you're being more productive, obviously, with your staff time, because these patients are moving forward with treatment at double the rate they would be as an out-of-network provider. Also, you're going to be able to work with the medical community. You're going to generate referrals from the medical community. So as I touched on earlier, physicians like to refer to in-network providers. They don't want their patients going somewhere where they can't afford the treatment. They want their patients treated. So when you're in network, you can market yourself as being an in-network provider, not just on your website, not just directly to your patients, but if you're at the stage where you're ready to go market yourself, maybe you've done this, maybe you've treated 20 patients, maybe it's your second year in dental sleep medicine, and you got your feet wet and you have some great results with the patients that you've treated. Yeah, that's a time. It's time to go get out there and have an outreach program to these physicians in the medical community. And it's extremely important, if you are going to go out there, that you are in network with most of the insurance carriers. Maybe not all of them, but you're in network with most of the insurance carriers. And you can tell the medical community and these physicians that, yes, you are in network. The patient can't get a better deal no matter where they go, that they go to you. So that's going to be a big benefit. And we see that, again, we see the growth when our practices get in network from those referrals from that medical community. You're also going to be able to compete with PAP treatment. So a challenge to competing with PAP treatment isn't the clinical side. If you ask most patients, would you rather use oral appliance therapy or would you rather use PAP therapy? They're going to say oral appliance therapy, right? So getting patients to decide, if they see a sleep physician and the sleep physician advises them, okay, here are your treatment options, right? And their treatment options are PAP therapy and oral appliance therapy. Well, they're going to want oral appliance therapy most of the time. But what's going to stop them from getting that oral appliance therapy may be finances. Because if a patient goes down the street to Life Care Solutions, Lincare, Apria, and they get quoted for PAP treatment, those providers are in network. So that patient may only have to pay $300 or $400 for the CPAP, the supplies, the hose, the mask, everything. So they can get on treatment maybe for $300 to $400, depending on where their deductible is at, versus if they go to an out-of-network dentist and maybe it's $1,800 out of pocket to the patient. Maybe it's $2,000. So perhaps they wanted the oral appliance treatment, but now they can't afford the oral appliance treatment. So you lose that patient to PAP treatment because of finances. So when you're in network, you can financially compete with a patient who has the choice of both treatments, and also compete on the financial side of both treatments, not just, the less invasive side of those treatments. All right. The other thing is, we mentioned earlier that medical insurance will try to drive patients away from you if you're out of network. But when you're in network, the insurance is going to drive patients towards you. So not only do you have the medical community referring towards you, but now you also have medical insurances referring to you as well, because you have the contract. You're a preferred provider now with them, and that's who they want their patients to see. So you're going to generate the referrals from the medical insurance as well. All right. I kind of feel like South Park doing the MK with y'all right there. Faster pre-authorizations and payment. That's going to be another thing that's going to be very beneficial to you as a provider. You're going to be able to speed up those pre-authorizations. Those pre-authorizations should be done within, if you're good at, having the paperwork and having all the clinical side of this completed, you're going to be able to get those patients and the pre-authorizations done typically in about 2 weeks. If it's the end of the year, please make sure that you account for probably 4 weeks, because everybody is trying to use their benefits before deductibles reset in January. So again, reminder for the end of the year, start acting now. Don't wait till the end of the year. But when you're in network throughout the course of the year, for the first 9-10 months, you're going to get pre-authorizations approved in about 2 weeks. And you're going to get payments much faster. In network payments that we see come in sometimes within 2 weeks. I would say on average, it's about 3 to 4 weeks for an in-network payment. So much faster, you're probably twice as fast as an out-of-network payment. That's average around 8 to 10 weeks. And some of the challenges to this model, you have to be in network with some of the dental insurances for Blue Cross Blue Shield plans. That is in a lot of the states, I would say probably half of the states do require that. So I tell practices, first thing I do is we'll find out what state they're in, find out what, obviously present what that contracted rate's going to be. But let's just use South Carolina as an example, because it's a pretty big difference there in South Carolina. If you're out of network, even if you're getting a gap approval, they price the out-of-network claims at $1,100. That's the allowable. So your payment's probably going to be around $700 to $800, depending on the patient's cost share and deductible. Well, in network, if you're in South Carolina and you're in network on the dental side, you can get DSM, dental sleep medicine payments at $2,200 or allowables at $2,200, and patients have much better benefits in network. So payments are probably going to be around $1,800. So quite a big difference. So I always talk to practices in South Carolina and just say, first question I ask is, are you in network with dental? If they're already in network with dental, it's a no-brainer to get in network with medical. Same with North Carolina, same with Maryland, same with a lot of states that offer, rates at least $1,800 or above to be in network with Blues. To me, it's a no-brainer. You're already in network on the dental side, get in network on the medical side for dental sleep medicine, in these states, so that you can take advantage of that. It is a challenge, though, if you don't want to be in network with dental insurance at all, then obviously you're not going to be able to work with the Blues. And, that is something that you have to consider. And a lot of practices, if they're not in network on the dental, they're not going to just get in network with Blues for medical unless they're creating just a dental sleep medicine practice, a standalone. So that is a challenge for some of the states. All right. And be prepared for volume. So like I mentioned, you must be prepared for volume. Something that we do as a business, we always run our company at least 3-4 employees heavy. So we have close to 40 employees here, and we run about 4 employees that are just floaters. We always know to cover vacations, for increased business, whatever it is. We're always prepared for increased volume. If you go in network, you're going to double, triple, quadruple your volume in about 3 to 4 months. So just be prepared. Don't get overwhelmed. Have the staffing, have the training, and be ready to be able to take on that volume, because a lot of people are going to start referring to you. Okay. So that's it on those models.
Randy, it looks like you froze there, or else I froze.
I think Randy froze. Or did he get kicked off?
Yeah, I would love to be able to have him answer these many questions. And we had several questions about Medicare. I wonder if he knows that he's not.
Yeah, I'm going to call him right now if everyone can just hang tight for 1 minute, because I know you have some really good questions.
Yeah, we had a couple Medicare questions, and he looks like he was getting ready to answer it. Yeah, we have probably 10 questions that
It looks like he's back on.
he's back on. Okay.
Oh, I had a hiccup there.
Yeah, no problem. It's a crazy internet day.
Yeah.
You had a slide up about Medicare. Do you want to go ahead and talk about that?
Yep. All right, back on. You got the slide?
Yes,
you got it.
Perfect.
Great.
Perfect. Okay. Sorry, everybody. So yeah, with Medicare, a lot of dentists get into this and they don't know if they want to get in. They went through the whole opt-in, opt-out many years ago, but they don't quite know if they want to get into working with Medicare or working with the government. Some of them are afraid that they may be audited by Medicare. I've never seen a dentist audited by Medicare. We do have Medicare ask for records sometimes, prepayment review audits, just to make sure that the patient does qualify. So that's something that Medicare will do, but I wouldn't be concerned about working with Medicare as far as audits go. I think it's very beneficial to work with Medicare. And we talked earlier about getting physician referrals. Again, you want to be able to tell physicians, if you're taking dental sleep medicine to the next level, you want to be able to tell physicians that you are a Medicare participating provider or non-participating provider, that you're enrolled with Medicare to help those patients obtain coverage. So the way Medicare works is we enroll all of our clients as non-participating DME providers. DME stands for durable medical equipment. And that's what the appliance falls under in, Medicare's eyes. It's durable medical equipment, DME, POS, prosthetic orthotic supplies. And you can enroll as a non-participating provider, and there is no limiting charge for DME providers. So you can set your fee at whatever you want to set your fee at. So in Florida, for example, obviously there's a high Medicare population base there. And 1175 is not very much to be profitable in that region. So what they'll do is, they will charge Medicare, or Medicare providers in Florida will charge the patient $2,000, $2,200, whatever it is, charge the patient up front, and then the patient can get reimbursed up to, say, 1175 from Medicare and their supplemental plan. So when you're a non-participating Medicare provider as a dentist, even if the fee is only 1175, you don't have to accept that. You don't have to accept assignment. You can set your own fee, and a patient can be reimbursed up to Medicare's rate. And that is something that happens quite often throughout the country. Most of our practices don't accept assignment. They have a model where they're collecting up front from the patient, and Medicare is reimbursing the patient directly, whatever that fee may be. So they're using Medicare to help supplement that cost. Up in the Northeast region, New York, Massachusetts, Maryland, Pennsylvania, you're at a little bit better advantage there. The fees around 2,100. So some of those practices, they may accept assignment, for those patients, just on the sake that they're going to be doing volume, and they're appeasing their referral sources. So it just depends. There's 4 different regions with Medicare. The Southeast is around 1175. The Midwest and the West is right around 1,500 Medicare's rate, and the Northeast is close to 2,100. But you have the freedom to set your fees. Alrighty, and then some supplemental plans. So with Medicare patients, a lot of them will buy supplemental insurance to cover the difference. Their deductible, their 20% cost share, some of their pharmacy items. So they'll buy supplemental insurance, and there's supplemental insurance that are type F or type G supplemental plans. And sometimes with those plans, they'll pay all the way up to $5,000 for the treatment. So some of the Medicare patients, most of the Medicare patients, I'd say 80% are going to have a traditional supplemental plan, and you'll get your regular fee for that. But I'd say 1 out of 5, 1 out of 6 Medicare patients will have that type F or G, and you could get up to $5,000 for those treatments. Again, like I mentioned, you enroll as a non-participating provider so that you can always set your fee. So I think it's very advantageous to help Medicare patients. There's a lot of Medicare patients that do suffer from sleep apnea, a lot of Medicare patients that can't tolerate PAP therapy. So I think it would be very good for a dental practice to enroll with Medicare as a non-participating provider, and then they can set their fees however they want to set their fees. Alrighty. So just wrapping this up, some words of wisdom: just be patient with the process. Just understand when you're using medical insurance, not to jump the gun. I would say the biggest mistake our practices make is delivering an appliance before the pre-authorization is approved and that pre-authorization window of treatment is established. So just be very patient with the process, be very patient with medical insurance, get your patients involved when needed. You shouldn't have to unless you're doing gap approvals here and there. The other thing I'd say is have a good system for sleep testing. I see a lot of the old style, the old ways of doing this, where the dentist would purchase their own sleep testing device and just send it home with the patient. That's very hard to do now with medical insurance, because medical insurances will now, some of the insurance will require face-to-face with a physician. Medicare has always required that. Medicare replacement plans, United Healthcare requires that you have a face-to-face with a sleep physician. Cigna is moving that way in their policy. So what I recommend now today with dental sleep medicine is that you have a good partner, whether it's a local sleep physician, whether it's a national home sleep testing company that offers telemedicine visits. You need the physicians involved more than ever to get medical coverage for your patients. So that's another thing I would say, that you have a good testing system, and that testing system is very easy for your patients to access sleep physicians, to have those documents ready for yourself when you're going through the pre-authorization process. And like I mentioned, staff accordingly. The other thing that we hear quite often when we sign up new dental sleep medicine practices is the doctor really wants to do this. It's very rewarding to help their patients in this way, improve their patients' lives, perhaps even save a life. But their staff sometimes become overwhelmed. Doctors bringing in something new. Make sure that your staff has the support, the training, and the time to work this program. And if you do that, and do some of the things that we talked about here, you can become very successful with this. I've seen hundreds of practices succeed, but I've seen hundreds of practices fail. If you listen to the right people and get the right guidance, there's a lot of opportunity coming up. You probably hear more now than ever and see commercials for CPAP therapy, Inspire. The awareness of sleep apnea is just starting to peak. And I think there's a lot of opportunity for dentists to get into this, that go down the right road with this to be very successful. All righty, that's it. I'm open for questions.
Oh, we have questions. We have questions. So let me just pick up. You mentioned some of these plans are now requiring a face-to-face. Two people want to know, is telemedicine considered a face-to-face?
Yeah, fortunately, so Medicare actually changed their policy, and that's a great question. Medicare actually changed their policy last year to the verbiage in their policy to state in person. They used to say face-to-face in their policy, but they changed it to in person. But because of the Congressional Appropriations Act of 2023, they extended the telemedicine visits to be considered an in-person or face-to-face visit to at least the end of 2024. So at this point, Medicare was the only one that we were concerned about. But they are good all the way through 2024 based on the Congressional Appropriations Act. United Healthcare is another one that does require a face-to-face. United Healthcare is the only one that does specify that face-to-face has to be done by a sleep physician or somebody working directly under a sleep physician, like a physician assistant or nurse practitioner. But yes, telemedicine does work with every insurance carrier at this point to adhere to the face-to-face requirement.
Excellent. I'm going to stay on Medicare for a minute because there are a couple more really good questions. So what do you do? You have a Medicare Advantage patient where the reimbursement is only like $900 and the patient is told that the dentist can't bill for any additional fee. Are you stuck there? Is that where you are?
No, you're not. So, and that happens as long as you're transparent to the patient up front. So you have the No Surprise Act that also came out of Congress, the No Surprise Bill Act. So you have to be very transparent with the patient up front. And if it's a Medicare replacement plan and you're not contracted with that plan, you're allowed to set your own fees. You can use a couple different models like we discussed, but you just have to tell the patient up front what their cost is going to be and what the expected insurance payment is going to be. And we have seen Medicare replacement plans pay that low, sometimes even a little bit lower, like 800, 700. But you do have recourse as long as you're transparent to the patient at the very beginning and giving them an accurate statement, and then just own that. You can't go back and charge the patient.
But when the patient says, hey, I was told you're not allowed to collect any difference, you just have to inform that they are not correct.
That you are not contracted with that insurance carrier.
Exactly. What about Kaiser? Here in California, that's a huge program? What's your experience with Kaiser?
Kaiser is they have their own network. So and that network is through SomnoMed. And so you have to work with SomnoMed if you want to treat Kaiser patients. Up in the Northwest, they do have some Kaiser PPO that you have that freedom. But with Kaiser, it's very difficult unless you're in that network with Kaiser. Otherwise, they're very strict. They're not going to give an in-network exception. They're not going to give you a gap approval. You just would have to charge that patient cash if they didn't want to go through their 7 steps to get treatment with Kaiser.
Okay. Now I got a couple really interesting questions about going in network and out of network, and I know you handle these really well. So you mentioned TRICARE, and this doctor says in his area he's never had a TRICARE patient, but if he goes in network with TRICARE, do you think he'll start seeing them? Is it a very common insurance program? I mean, how do you know if you go in network, do you suddenly start seeing these people that you'd never seen before?
Not really with TRICARE, because that's going to take a relationship with the TRICARE base doctors, their physicians, and they're very strict on if you want to.
Those are active duty military, correct?
And retired. Yeah.
And retired. Okay.
And retired. So they have a little bit more freedom when they're retired. But to answer the question, it's basically the demographics. Obviously, down here in San Diego, we have the naval base, we have Camp Pendleton. There's a lot of TRICARE retired and active duty. If the doctor's in an area that doesn't have a lot of TRICARE, there's no military base around, and there's not a lot of retired there, then being in network with TRICARE is not going to turn around and generate a lot of TRICARE patients for them. The best way to get to work with TRICARE is to just pound the pavement and build relationships with the TRICARE physicians for referrals.
Got it. Okay. So talk about, how do you become an in-network provider? Is there some kind of credentialing program, and how does the office get signed up to be an in-network provider?
Yeah, it's a great question. So first, the network has to be open in that area. So you have to contact the liaison for the insurance, the networking liaison for the insurance carrier, and see if they're accepting any new providers in the area for dental sleep medicine. If they are, then you're going to go through the credentialing process. Some of the insurance carriers will use Medicare to do basically their vetting. So with Regents up in the Northwest, in order to get the Regents contract, which is a fair contract, it's $2,500 through Oregon, through Idaho, through Washington, you are required to become be a Medicare provider as well. Because Medicare, you got to do the background check, you got to do the fingerprinting. Medicare wants to make sure that you're a legitimate provider with all the Medicare fraud that's out there. So some of the private insurance carriers will piggyback off of that and require the dentist also be a Medicare provider. Not all of them. Some of them you can have a contract and go through their own vetting process. But yes, the first step you would take is to reach out to the insurance carriers and find out if the network is open. And if the network is open, the next step is to apply to become an in-network provider.
Okay. And I know we're not trying to do a commercial for your company, but is that something that your company helps doctors with?
It is, because it does take some contacts and some connections at times to get through to the right people. So I'm sure everyone's kind of gone through that where they can't even get to the right person to find out. But yes, we do help the dental sleep medicine community get contracts. Whether you're a client or not, we offer that service.
Oh, that's nice. Okay. And then do you have a slide with your company info in case anybody has questions they want to reach out to you? So we got a couple now, this same doctor has submitted 2 questions that are kind of similar, and he's asking, considering all the payment delays and gap approvals and mistakes processing claims, how long does this take start to finish, from pre-authorization to getting the check, and how many hours of per patient is our administrative staff going to work? I think this doctor is coming to the question of, is it really worth it?
Yeah. Yeah, and that is a challenge. So if you're out of network in your area where you can get the gap approvals, it's a little bit extra work. If you're using a third-party billing service, it's not extra work for the practice. The practice is going to do what they got to do, whether they're in network or out of network. Their role is to get all of the clinical information, right? So have all the clinical information. From there, they should be passing the torch if they're using a third-party service, passing the torch to that third-party service, and that third-party service takes it on from that point. To answer the question of how much, if you're doing in-house billing, yeah. If you're trying to do this yourself and bill it yourself, it's a lot of work. For us, when we work, that's why we give a price discount to in-network providers versus out-of-network. We have to cover the extra cost out of network. It's typically going through the gap process and going through the claims process and then having it reprocessed. It could take 7 to 8 hours of a person's time to get everything correct. But that shouldn't be coming from the dental practice. That should be coming from the billing service.
Got it. And just to clarify, this where you said there was a federal law that made telemedicine qualify as in person. When does that expire? How long is that?
December 2024.
Okay, so it's good for another year and a quarter.
Yeah, and if anybody wants to research that was part of the Congressional Appropriations Act of 2023.
Okay. And as far as your clients, do you have a minimum number of cases that a client has to be doing, or can you bill per case?
No, we don't have a minimum. Honestly, most of our clients only do 2 to 5 cases a month. Obviously, we have high volume clients, but because we have so many clients that are new or getting into this or just doing, a few. Most of our clients are doing between 2 to 5 cases per month.
Great. So if an office is starting to get gap denials, so they were getting accepted for a while, now they're getting denials, is that a way of deciding that it's time to go in network? Like in this particular doctor's case, he was trying to wait till his volume was at a certain level before he went in network, but concerned about losing cases for being out of network.
I would say yes, because at that point there is somebody, and if it's legitimate gap denial, sometimes the insurance will deny the gap because there's an oral surgeon. They'll deny the gap because they have a DME provider. But if there's truly somebody in the area that is treating dental sleep medicine that is in network, then I would say that is a time to look at going in network, because it's going to be very challenging for you to treat these patients. The out-of-network model without the gap denial is hard because the deductibles out of network are typically going to be $1,500 or more. And most patients do not see out-of-network providers throughout the year to apply towards that deductible.
Got it. Okay. And obviously the key to building a good dental sleep medicine practice is to have some good relationships with sleep physicians. How does a practitioner go about creating those relationships?
I think the first year or two, it's organically. You do that with follow-up letters. I always advise our practices that are brand new to this is, hey, just start within your own practice. Don't go out and tell the world that you're doing this yet. Help your own patients, help all the practice. 1 in 5 patients are, by the numbers, or have sleep apnea of some form and are undiagnosed, right? So I always advise our practices getting into this for the first year or two, just help your own patients, get some case studies, build up some success stories. And then when you have these success stories, reach back organically to that patient's cardiologist, to that patient's primary care physician, to that patient's pulmonologist, and do it organically. Once you've done that and you start building that relationship, then at that point, I would say maybe it's by year 2. You've done this a couple of years, or you've done enough in a year, you can go out there and start doing some lunch and learns and working with the community, and maybe hiring somebody that's going to go out there and pound the pavement for you and start doing an outreach program to the medical community.
Exactly. Think about when we choose a specialist to work with, we refer to people that take good care of our patients and that it's easy and seamless to work with them. And that's the same thing that a sleep physician is looking for. So you have to show them that you know what you're doing. You can handle their patients in an efficient way and get them treated. So it's the same kind of a thing. I'm going to finish here.
One more thing, Dr. Park, on that. Another good way to organically market, if you're testing all these patients in your practice, you're going to have some patients that come back severe sleep apnea, right? Well, that patient should go on a PAP therapy before they go to oral appliance therapy, because most insurances are going to require that, and that's the standard of care. Somebody that has severe sleep apnea should go on PAP therapy. So another way to start reaching out to these sleep physicians is when you're testing and you're identifying some patients that have severe sleep apnea, refer those patients, give them some referrals. The DME providers in your area, refer to them. So when the DME provider has intolerant patients, they start referring those intolerants to you, and you're referring severe sleep apnea patients to them. So it's a way that you can use that as a bridge to that medical community.
Great advice. All right, I'm going to finish here with such a typical question you have when you're dealing with insurance. So the doctor says we did a pre-authorization, we had gap approval with Blue Cross Blue Shield, we did the appliance, we sent in the claim in May. We have not received payment. We've called 10 separate numbers and we can't get a person. We sent emails with no reply. How do we get paid?
You got to just keep pounding the phone and talk to supervisors. So that's what we have to do. Our billing team is on the phone all day long, and we have a call reference number. We track everything. And at a certain level, you just ask for a supervisor at the insurance carrier, and you go back and read all of the notes that you've taken from the previous calls with the reference numbers, and you ask for them to expedite this. You just be as forceful as you can, because the insurance is going to try to hold this. They play the delay game quite often. So you just got to be very persuasive and get to supervisors.
Yeah, and I know you're too modest to say this, but that's where a medical billing service really comes in. They're professionals. They have contacts within the insurance agencies. They know who to talk to. They know what number to call. So yeah, if you want to put your contact info up, that would be great. And Randy, this was excellent. I know this is something that dentists struggle with, and you've got a really good way to look at it. And I think people can make decisions based on what information you've presented today. And we appreciate it. And I want to thank our panel. Oh, Randy, go ahead. You want to say something?
Do you see my screen right now? I do have my contact information.
I have your face. I see your face.
Okay. I did put it in the chat, but okay. I don't know if it's your.
All right. Well, it's in the chat. That's great. That's good enough. Good. Thank you, Randy. Thank you, panel. Thanks, everyone, for joining us today. There it is, pristinemedicalbilling.com. And be sure to join us next week when we'll have another Randy. We'll have Dr. Randy Resnick will be returning, and he'll be talking about peri-implant disease, and in particular, how the prosthesis design can be a contributing factor. I'm looking forward to that. So thanks, everybody, for joining us today, and we'll see you next week. Take care. Thanks, Randy.